Welcome to Nursing 342, Medical Surgical Conditions in Childhood. Session 7, we are looking at imperforate anus, vagina, and spinal bifida. So we are still on the congenital malformations. So for this session's overview, we seek to discuss imperforate anus, vagina, and spinal bifida. These disorders may be apparent at birth or may be noticed when the newborn becomes symptomatic. The spinal bifida, there is failure of the neural arc and the vertebral column to fuse during embryonic life, which permits the meninges and sometimes spinal cord and some neural nerves to protrude. And students will be taught the etiology, the clinical manifestations, diagnosis, and management of these conditions. Our goal at the end is that students will be able to define imperforate anus and vagina, as well as spinal bifida, discuss their etiology, clinical manifestations, and explain the management of their conditions mentioned. So the key topics we'll discuss are imperforate anus, imperforate vagina, and spinal bifida. Our reference reading is chapter 24 and 32 of Wong's Essential Pediatrics for Nursing. Imperforate anus. This is a congenital defect in which the anal opening is absent or blocked. We all know that the anal opening is where we have the stools or fecal matter leaving the body. And other forms include anorectal malformation and anal atresia. So we'll view the imperforate anus here as X-rays is showing it. And here you see that the incidence is 1 in 5,000 births, and it affects girls more than boys. And 90% of the time it is in females, and 50% of the time it occurs in males. The cause actually is unknown, but is believed to have some genetic basis and is very complex, and there are various anatomical variations. They occur in association with some genitourinary and musculoskeletal as well as neurological system anomalies, and also some chromosomal anomalies, as we have discussed earlier. And in 80% of genetic factors are clearly associated with imperforate anus, and then occasional complications of sacrococcygeal teratoma. Forms of imperforate anus occurs in several forms, and it may be that the end of the rectum will come as or present as a pouch and does not connect to the colon. The rectum may have opening to other structures like the urethra, the bladder, the vagina, and even the base of the penis or rectum. And it may also result in some stenosis where there is narrowing of the anus or no anus at all. So what do we see? Visible membrane at the site of the anus, or failure to pass meconium within 24 to 38 hours. So eliciting this is important. And stools pass out of vagina or penis because of the association, or swelling belly or abdominal distension. Initial physical examination of the newborn helps us to diagnose this. Imaging tests may also be recommended, or ultrasound can be used to determine the type of perforation, imperforate anus. So the treatment basically is surgical in nature. Surgery is conducted to create the opening, or anoplasty, where there is no anus at all, or in some cases there is the need for some form of dilatation to help bring out, if it's membrane that is covering it, and most successfully corrected is by manual dilatation or surgery. Nursing management, there is a need to assess newborn's perineal area and make sure that is not poorly developed, and then also we record anything abnormal that we find. Initial management, this when established, the child is put on nail per os, and then we have intravenous fluids, and then also nasogastric tube may be passed to decompress the stomach in cases where there is some distension with fluids, gastric fluids. And there is a need also to monitor input and output, and then also measure the vital signs 4-hourly and provide emotional support to the family, especially the parents or the significant others involved in the care of this child, and also educate them about the line of management in terms of the upcoming surgery where indicated. Therapeutic management, the goal of an erectile malformation in cases of surgery is to construct the anus in proper position. And in cases where there is anal stenosis, then dilatation is done repeatedly on the ward to create the opening and also sustain that it is established. And in cases where there is malformation of the lower rectum, then there is a need for anoplasty, surgery to be done to correct this anomaly. And in cases where there is high anomalies involving the large bowel, then colostomy is created so that the large bowel is brought on the anterior surface of the abdomen to empty it until the final correction is done. Post-operative management, when we talk about the maintenance of good hydration, we need to also give intravenous fluids and oral fluids, usually clear fluids as the bowel movement return, or also make sure that if the child is giving formula, we give half strength before full strength, but if breast milk, we give as the child can tolerate. And also in older children, there may be the need also, after the colostomy is done, we make sure that we give the child high fiber diet, 2 softness and enemas to prevent constipation. So this is very, very important. And then when we have colostomy care here, it's very, very important that the skin around the stomach is taken care of. We apply zinc for oxide creams that will help the skin to stay healthy and prevent breakdown. There is also the need to observe the fecal content and the condition of the skin, and also areas where we attach the pouch, the colostomy bags. We have to make sure that they are all healthy, and also we take care when we are peeling off the plaster so that we don't damage the skin. Assess also for common complications of colostomy, such as prolapse, retraction, breakdown of the skin around the stomach, or even stenosis, and the family's ability to cope with the ostomy, because there is a need to manage. If the child is going to go home and come back when it grows a bit older, then it is very, very important that we teach them how to care for this, because the child, we want him or her to live near normal lives. There is a need to give the mother adequate knowledge. So this is where we end our discussion on that. So now we are going to look at, we finished the imperforate anus, we'll look at the imperforate hymen. This is a condition, also a congenital anomaly, where the hymen is completely obstructs the vagina. There is basically no opening. And this is a picture to show. You see that there is no opening. You can see the clitoris there and then the anus. But you can see here that the hymen is completely sealed. So how does this happen? The actual cause is unknown. But once again, it is a defect that happened during embryonic life or during fetal development. And the incidence we are saying is 1 in 1,000 to 1 in 10,000 its most common congenital anomaly found in vaginal condition is a imperforate hymen. So once again, depending on the extent, if it extends, because we know that the urethra is 2.5 centimeters below the clitoris. So if the congenital anomaly is such that sometimes even the urethra is covered, so there may be urinary retention, and there will be cyclic pelvic pain because of the accumulation there, and then amenorrhea. Sometimes it may not go unnoticed, so the young lady has reached puberty and there is no menstrual flow, and there is also hematocorpus where there is accumulation of blood down vagina to the uterus, and there is back pain, nausea and vomiting, and all that we have said. So a pathophysiology, here we see that there is a problem at the fetal development in early life, and the sinovaginal bulb failed to canalize with the rest of the vagina, and this is the origin of the formation of the hymen. So there are instances where this is also being found to run in some families and has been reported, and also in sporadic cases where you find once a few cases around, and genetic markers and mutations have been linked to cause this. Once again, physical examination will all be to observe this at birth if we examine the perineum well, and also ultrasound can be done to diagnose this prenatally, and also abdominal and pelvic mass or bulging hymen will be visible in cases where patients come with a history of amenorrhea at puberty. So surgery is performed, and here we have, before surgery, there is a need to control or suppress menstrual cycle. So combine oral contraceptive with estrogen and progesterone is given to suppress the menstrual cycle, and then we give NSAID because of the back pain, and all the discomforts associated are also relieved. So hymenotomy is typically involves taking or breaking or incising in the hymen, and also here, when this is done, then any vaginal blood or whatever is there is also drained. For the affected girl whose parents wish to have the hymen preserved, surgical techniques are used to also ensure that the hymen is maintained, even though the intervention will bring about the incision. After surgery, dilators are put in the vagina 15 minutes each day to keep the incision from closing and also keep them patent. There are some complications associated with this, as you can see: peritonitis, constipation, urinary tract infections, and all that. And also, we have said that once again, CT scan, MRI, and ultrasound can be used. So this brings us to the end of our discussion on imperforate hymen, and now we will proceed to look at spinal bifida, which is our third topic. So it's also a congenital neural tube defect in which the vertebrae fail to fuse posteriorly, leaving a space through which the meninges and spinal cord protrude, and is usually in the lumbosacral region. The actual cause is unknown. However, there are some risk factors to do with maternal medical conditions, even rubella, genetic malformations, and some environmental factors. As we started talking about congenital anomalies, we have talked extensively about these, and I think this shouldn't be a problem now. And how do we prevent this? Also, folic acid before pregnancy is known to prevent this, and also in first trimester or few weeks of pregnancy is also known to reduce the risk of developing spinal bifida. There are two main subtypes. We have the Spinal Bifida occulta, where there is no visible, no defect seen externally, no protrusion, and the defect is hidden. And then the second type is the Spinal Bifida cystica, where there is visible sac-like protrusion. And under this, we also have two subtypes. And it encompasses, we have the meningocele, where the meninges and spinal fluid protrude through the bony defects, and thus forming a neural sac. And here, there is no paralysis and no sensory loss because no neural elements are involved. And also, it is important to note that because the neural sac is also protruding, there is a likelihood of getting it infected. So surgery is done to prevent this complication of meningitis and others, and so the sac is closed. A more severe form is the myelomeningocele. Here you have the meninges, the nervous tissue, protruding through the vertebral column, and is associated with neurological deficits of varying degree. Anencephaly are all under this category. And the treatment involves many specialists, the pediatrician, the neurosurgeon, all come on board to work. And here we need advanced nursing skill to care for a child with neural tube defect or spinal bifida. And the surgery closes, and then the child requires years of follow-up and therapy. So what about our nursing management? We are saying that at best, newborn initial examination is very, very important. So though we perform it routinely, we should do it with a lot of attention. And also, if there is any neurological impairment, we need to elicit this. And physical assessments will involve eliciting the various responses to stimuli, and also the various reflexes are also examined. And there is a need to also take the various head circumferences, look at the newborn, and also the fontanelles need to be examined, and also the back where the defect occurs in the lumbosacral region. And also there is a need to offer support in cases where this is diagnosed to the family, because we all know that it comes with a lot of trauma. So they need to be supported, and also given the necessary information about help that is available, and also giving all the information they require, and all their concerns addressed, and misconceptions also corrected. So it takes the establishment of a trusting relationship with such families to be able to divulge the information and their concerns and address them. One of our key goals is to prevent infection. So it goes with giving prescribed prophylactic antibiotics, and also handle the sac aseptically to prevent infection. So it's very, very important that we wash our hands, don our gowns and gloves appropriately, and also change dressing in cases where the sac is exposed, and we cover with saline to prevent it from drying and breaking down. There is a need to ensure that we maintain sterility and the moisture. So we ideally every 2 hours, this should be inspected and changed. And also we need to prevent contractures of lower extremities. So there is a need to teach mothers, and also involve the physiotherapists come on board to help us with range of motion exercises of the lower extremities, especially in where there is loss of or paralysis, especially, and so we prevent contractures. And also there is a need to abduct the hips and the feet in the neutral position, and massage the knees and other bony prominences. So once again, we need to bring the physiotherapists on board, and also involve the family, because such a child will go back home, and there is a need to give them the necessary knowledge and skill to be able to manage at home. And after surgery, we need to prepare the family about the care of the infant at home. So as I said earlier, we need to work with the family, and this promotes family-centered care, respect their concerns, and help them, and discuss strategies to stimulate sucking and stroking of the infant's cheek, and if it needs to express the milk and feed with cup and spoon, we teach them how to do that. And the family is also taught how to care for the child and how to recognize signs of complications such as increased intracranial pressure, hydrocephaly when the head circumference is increasing, and urinary tract infection, among others. For our assignment, I want us to look at how will you prevent infection in spinal bifida? What measures will you put in place to promote collaboration with family? There is a video I have uploaded on Sakai, and you need to view this to also help you understand. This is where we end our session, and the reference is here.